Hello, everyone. Welcome to the presentation. Thank you for finding the time to join us today. My name is Jesse Lehman, and I'm the founder of Kerrier, and we make the Kerrier Absorbable Bead Kit for infection cases. Since launching 5 years ago, Kerrier beads have been used as an infection management tool in a wide variety of cases all over the world. Veterinary surgeons are using the beads to deliver a high concentration of antibiotic locally to sites where infection is present or anticipated. Calcium sulfate in the kit is surgical grade and fully absorbable, unlike PMMA, and the sterile kit is easy to use and affordable. We're excited because today, Dr. Allison Stewart with the Tennessee Equine Hospital will be sharing some of her experience with absorbable bead use in horses. At the end of Dr. Stewart's presentation, we will answer questions, so please send them in through the Q&A box. This webinar will also be recorded and made available at kerrier.com. So let's get started. I'll pass it over to Dr. Stewart.
Good evening. It's my pleasure to speak to you this evening about absorbable antibiotic beads. Can everyone see the screen?
Yes.
Okay. So this evening, I'm going to talk about absorbable antibiotic impregnated beads to treat horses with severe wounds, draining tracts, and infections. I started this work while I was at Tennessee Equine Hospital, and there was no proprietary interest or funding for this project at the time. And essentially, the co-author is Dr. McInturf. And if you look at the cases on the right-hand side of the screen, the top one was a severe pastern wound that was a barbed wire laceration that actually involved the tendon sheath. The horse had 220,000 white cells in the tendon sheath, and the owners were unwilling to do standard therapy. At the time, I had just made up some over-the-counter calcium sulfate beads, and we got to do one regional limb perfusion, inject the tendon sheath once, and we put beads in the wound, and that horse went on to heal. The other one was down in the right-hand corner. That was a mini that was attacked by dogs. And the infection was really severe at the time when we saw it. And again, the wound was pretty badly contaminated, and also the blood supply looked compromised. So IV deliverance of antibiotics was probably low, and we tried beads in that case with antibiotics, and it worked. And that kind of got us more keen to do more work in the area with the absorbable beads. I do have a previous history of looking at local antibiotic administration through a catheter in the joints in the tendon sheath. So this is kind of an extension from where I've been in the past. So when we talk about local antibiotics, when are we really looking to use them? We do know they improve resolution of infection in cases that have heavy contamination, severe tissue trauma, compromised blood supply, maybe some chronicity with a biofilm and or fibrinous exudate. All of those factors give bacteria a place to hide and make it very difficult for the blood supply to get effective concentrations there with IV. So the gold standard is 8 to 10 times the MIC with local antibiotics will improve the resolution of infection in these severe cases. You can see this wound here on the right had all of the above, and also involved the fetlock joint and the tendon sheath. So obviously when direct injection can be done, I would always prefer that. So if it's just a joint involved and it doesn't have a cellulitis, I'm going to stick to the traditional direct injection of the joint. And that will give you high synovial fluid concentrations. And if we use, as we talk about this, we use an antibiotic like amikacin, which is kind of our gold standard, that will give you high concentrations. So basically 500 milligrams or 2 mLs of amikacin directly injected into a joint will give you 2 days of 8 to 10 times MIC. And then it's time to repeat the injection. Cases where it's not appropriate, if the joint is open and draining and you inject it and it just flows out through the wound. But it is a simple technique. It leaves nothing behind. And, that's going to be the gold standard if you have a closed joint infection without cellulitis. Regional limb perfusion, when would I consider using that? Regional limb perfusion, where you apply a tourniquet above the area and actually inject a vein below the area, would be the gold standard if you have tendon and bone involvement plus or minus synovial involvement. So if you have also soft tissue, heavy soft tissue involvement, then direct injection into the joint alone is not the most appropriate thing. A regional limb would be. Obviously, we're going to go for that when we have devitalized tissue, osteomyelitis, tendon involvement. And I have been surprised over the year how much tendon can harbor infection because it has a poor blood supply. So don't discount a cut that goes into the tendon as being innocuous, because some of those can be quite difficult to treat. And then everybody knows synovial involvement is a serious concern, and then cellulitis. So when am I going to use local impregnated beads, antibiotic beads? I want to use absorbable. I've gotten away from using non-absorbable because 6 months down the road after the infection's resolved, you can have a draining tract. There are multiple case reports. A big case study that actually showed with the non-absorbable beads, you may get up to a year out and then have a draining tract from the bead. So I would always recommend using absorbable beads. This is a classic case. This is an abdomen on a stallion that tried to get over a T-post. You can see the T right there imprinted on his abdomen where the laceration occurred. And essentially in a region like this, regional limb is impossible. It was a heavily contaminated wound. If you have a chronic established wound, it's also appropriate. And I often will use the antibiotic beads in addition to a regional limb perfusion or a direct injection of a joint. And usually I typically like to use these in wounds because you have the entry area and soft tissue surrounding it that is heavily contaminated. I would say I have also used beads. I think many of us in equine have used it for sarcoids with cisplatin. Those were commercially available. And in my hands, those have been more effective in conjunction with surgery than any other technique. I also have started using them with antifungal. And I saw that Kerrier had amphotericin B. I have used, I basically have used fluconazole. The only place I would be very careful of not putting beads is in a joint. So it's been shown that the non-absorbable beads are very irritating to the joint. And I haven't seen any studies, but I don't think the calcium sulfate would be appropriate in a joint. I do put them in an entry wound in the soft tissue surrounding the area, but not directly in the joint itself. So basically, this case study was a retrospective study of cases that had severe infections that were treated with local absorbable antibiotic impregnated beads from myself and Dr. Colton since 2021. When we first started, we used the over-the-counter product of calcium sulfate, which is essentially plaster of Paris. And then I'll explain why later we transitioned to carrier beads because of the cleanliness or the medical grade quality of the calcium sulfate, and also the bead mold itself is much easier to use, and then the beads are nicely formed and you can implant them much easier. So we looked through these studies and we basically obtained information on what type of infection was it, and we broke it down into categories of lacerations, chronic draining tracts, or a hematogenous spread. And that's been shown in other septic infection studies that these have different origins of how they occur, and they have a different outcome typically. We also look to see if known factors that give you a more guarded prognosis also had an effect in this study. So we essentially looked to see if there was synovial structure involvement and took note of that, if there was bone involvement with infection and took note of that, and if it involved the foot. We recorded the number of times that we replaced the beads and the type of antibiotics in the beads that were used. So when we first started this study, we knew that if we used, based on the literature, if we used absorbable antibiotic impregnated beads of just what we could buy for calcium sulfate, not the carrier, because I think they have longer release, that you would get 1 to 2 weeks of release of antibiotics from amikacin all the way to penicillin and vancomycin. When we first started this, we would use 30 grams of calcium sulfate, and then essentially you would use anywhere from 14 to 16 mils of liquid combined with 30 grams to reconstitute to make a bead. Our typical concentrations were 4 mils of amikacin for a 30-gram amount of calcium sulfate, and then add 10 mils of saline. So this is quite a large volume of bead and liquid, and we had a lot of wastage with this process. We made teardrop type beads to start with, and those are not very user-friendly for implantation. You can see here, meropenem is essentially the equivalent in human medicine of imipenem without the silastin, which is inhibits cell wall synthesis degradation. And then penicillin, we would use the whole 10 million units, and then vancomycin, we would use 1 gram. If you look at the outcomes assessed, we were looking for resolution of infection. The number one thing we looked for in the initial stage is, did we resolve the infection? Okay, if we resolve the infection, then what was the long-term outcome? Did they return to their previous level of performance? Were they pasture sound or stall rest? And finally, the worst category was euthanasia, or they died. Descriptive statistics were done because this were 55 horses is a pretty low case number. Okay. Essentially, all cases were treated with traditional therapy, which was broad spectrum antibiotics, lavage of the joint if it was involved, and local injection of the joint in addition to the bead. You can see on the right-hand side of the screen, we chose carrier unsolicited at that time because the bead mat itself gave you an option of either 5 millimeter beads or 3 millimeter beads. And I don't know how many of you have used 3 millimeter beads, but that's essentially what the cisplatin ones were that I had been using for tumors. And essentially, you can make a stab incision with a 15 blade with the 3 millimeter and expand that with a pair of mosquito hemostats, and then put the 3 millimeter bead in through just a tiny stab incision. In the beginning, when I was doing this, I would do one little suture of 2-aught Vicryl, And I've gotten away from that to where I just use tissue glue to seal the bead in under the skin. In our study, the beads were always broad spectrum. They either were amikacin and penicillin or amikacin and meropenem. And the beads were replaced anywhere from 1 to 5 times. There have been some studies, early studies, showing that the highest elution rate of the beads was in the first 2 to 3 days. So you could, in theory, replace the beads every 2 to 3 days to keep concentrations quite high. Although I think people have gotten away from this because more recent studies have shown that you're still well above MIC for at least 1 to 2 weeks. So that may have been excessive. In this study, there was a high number of difficult cases. In 29 of the 55 cases, which is essentially 53%, we had previous unsuccessful treatment with our standard therapy and then moved to using beads. If you look at Kerrier, if you use their product, they have essentially charts and recommendations for amounts of antibiotics to use, which is, you'll notice that the volume is smaller to fit in the bead mat. It's a total of about 15 mils of solution. Solution is probably the wrong term, but mixture that will fit in the bead mat to give you both 5 millimeter beads and 3 millimeter beads. They also, the products that they recommend here have a set time that is less than 2 hours. The things that didn't set in a bead mat would have been imipenem, enrofloxacin, and clindamycin. I can say that some of the things that don't set in 2 hours will set if you leave them longer and then gas sterilize them. So you can see on the right-hand side is kind of what we did in cases that we needed to leave longer than 2 hours and they couldn't be used fresh, or we had a lot of leftover beads. We would then package them in 20 beads to a gas sterilization package, and we would double package them, gas sterilize them, and then leave them on the shelf for when we needed them. And then we had beads on hand of broad spectrum. Usually we had at least penicillin and amikacin and meropenem and amikacin for when we had some severe lacerations come in. We had those right on the shelf. So when we looked at our cases, that gorgeous horse on the right was one of our earlier cases and had severe tendon involvement. Our total outcome would have been 87% had resolution of sepsis. So we resolved the infection with traditional therapy and broad spectrum antibiotic beads. Only 69% of those returned to the level of performance that they were originally at before they presented to our clinic. 15% were pasture sound. 1 was on stall rest due to severe laminitis, and 7 died or were euthanized. And I would say 4 of them died due to severe laminitis on the opposite foot, and in 2 cases on the affected foot that had a puncture wound. 1 died of colic, and 1, the owner quit because of loss of performance. That horse would have made a pasture sound horse. And then 1 case had a severe myositis. It was a Clostridium-like myositis. And we actually did the slashes in the muscle and the skin and put the beads in. And where we put the beads in, the myositis was under control, but we still couldn't save the horse. If you look at our results, most of them had some degree of synovial involvement, so I would have considered those severe. And you can see that the resolution of infection was pretty high, whether they had synovial involvement or bone involvement. I would say the worst outcome was cases that had foot involvement, where we had a 67% resolution of infection, but we lost 50% due to laminitis. We're actually, were euthanized due to laminitis. So I think when you have cases that involve the foot, particularly if they have bone involvement and are in the foot, then, that is a much more serious, difficult case to treat. The return to performance, again, when you look at the synovial involvement, it was 72%. When we look at osseous involvement, it's lower. It was 59%. I had a previous case series with when there was bony involvement, the prognosis would drop to 30% for return to performance. So this is slightly improved. And again, the foot, 33%. And again, the case numbers are low. These are typical cases that I had that were pretty severe injuries that also had synovial involvement. The one on the left was had penetrated into the carpal joint and had pretty nasty sub-Q infection in the tendon sheath area and locally in the sub-Q tissue, and then the joint was also involved. So in this case, we did regional limb, direct injection, and I put beads just in the sub-Q space where the wound was. And I feel like that gives us a quicker resolution of infection. The one on the right, I have used beads in cases where the owner is not going to let me do regional limb every other day for 5 times. And the best option I have in those cases is to put beads directly into the wound after I clean it as much as I possibly can, because it will continue to elute antibiotics at high concentrations for up to 2 weeks when I can only, basically address the wound one time. That is a huge advantage. When I looked at another case I had with osseous involvement, this was a really expensive horse. Money was not a limiting factor. We did regional limb, we lavaged the area, we did IV antibiotics and regional limb every other day. It still would not come under control. We took radiographs after about 7 days of treatment, and you can see there was bony involvement that you could see at the head of the splint. It was originally a kick injury from another horse. We saw it right away as well. So I debrided it after it had failed to respond to regional limb and IV Pengen and Metro. I debrided it, put beads in the area, and the picture you see on the right is how the horse looked a week after I put beads in. So I think there is something to be said for continuous release of antibiotic directly in the site of the wound. This is another case. The horse was unmanageable. When I was evaluating her, she reared up and went over backwards. We couldn't do much with her. We certainly weren't going to get regional limb done on her. She had a laceration that went into the coffin joint inside the collateral cartilage, and then had a lot of soft tissue involvement as well. What we did with her is put beads in and around the wound. We put a catheter directly in the coffin joint and closed it and put a distal limb cast on. And that horse, this is her, after the catheter was pulled from the joint, the beads absorbable beads had been placed sub-Q along this area. And this was her when we got to just putting a cast on their foot. That also, the laceration went right directly through the heel bulb, almost to the navicular bone. So this is her, I think, a month out. She's not sound, but she's pretty close for everything she had, and they just wanted a pasture horse for her. Again, they couldn't ride her. She was very, very difficult to handle. So something where we didn't have to address the wound frequently and or change her bandage frequently was a big advantage for that horse. If we looked at the injury type and how did that affect outcome, lacerations with beads had the best outcome. So resolution of infection was very high with that, and their return to performance was high. If you look at the ones that I found very frustrating, it would have been draining tracts, particularly in the inguinal area. So we had I would say a lower resolution of infection. And personally, I found them frustrating. We only had 22 cases. You can see only 50% of those returned to performance. And some of them were pasture sound, and 3 of them were euthanized. I had a particularly poor outcome if I had a draining tract that involved the foot. Those were hard cases, and I'll go over the reasons why I think they were hard. Hematogenous spread of infection, those were very tough as well. Those were typically growth plates and foals that were septic. And you can see we had a 75% resolution in infection. I think most people would argue if you can put beads right at the site of where the bone infection is at the growth plate, that's the best option that you have in conjunction with traditional therapy. We did put 1 down. These are some examples. This horse came in and had a laceration that went down to the scapula, had actually fractured multiple pieces off the spine of the scapula and was heavily contaminated. So we aggressively debrided it, packed beads around the spine of the scapula, and then put a Penrose drain in, and that horse went on to go back to full performance. These were very frustrating cases. This is probably a poor perspective that you can see the slide in the center, or the picture in the center. That was an inguinal draining tract. And we treated that horse with aggressive debridement twice. And the second time, based on cultures, we put beads in, and eventually she healed the draining tract, but she had a gait abnormality that looked like string halt. So I would not have considered her a success. And then the one that you see on the right was a draining tract from the very caudal aspect of the collateral cartilage that had originated from a foot infection. And we did regional limb with a bead and debrided and systemic antibiotics. And that one went back to full performance. Hematogenous spread, this is definitely one of the more severe cases that I've seen. This was a foal that had a growth plate infection that also fractured off the tip of the calcaneus. The foal came to us, I think, at 6 weeks of age, and was non-weight bearing at the time and had severe contracture of the leg. So I had a couple of problems. One, he was so severely painful, he didn't want to bear weight on the leg. And 2, it was deeply infected. So we used broad spectrum impregnated antibiotics, debrided that large fragment. And I did put some carbocaine actually in the bead as a liquid. I'm not sure that was an ideal use, but I figured if we didn't get him evenly weight bearing, he was going to break down on the other leg. He did go on he's being ridden right now. I would think that maybe morphine might be more appropriate. It maybe not, I guess a fentanyl patch, if we had it, would have been even better. But some other ideas to think about what you can add to the beads besides just antibiotics. And we have already touched on antifungal and chemotherapeutic options. The complications that we had by far and away the most severe were laminitis. And what I learned from this case study series was that most of our cases, 4 of them that were affected laminitis had treatment plates on. And so I was worried about a couple of things. One, the treatment plate may have transferred the weight to the outside edge of the hoof wall and allowed them to rotate more. And 2, maybe regional limbs play a part where you're putting a tourniquet on the leg frequently. I can say we went from a treatment plate that had an open bottom like you see here to where we started applying counter pressure as long as the wound wasn't involved in that area to the back half of the hoof wall. This is the horse that you can see went through a lot to get to this point of being healed. She felt good. She started rearing and bucking in her stall, and the next day she was this lame. And we took those radiographs that you can see, and you can see where she started to come through the bottom of her foot. And that was after, months of treatment. So I guess, I learned that infection in the foot, you need counter pressure. And then while the treatment plate really protects the foot from getting infected from the bandage falling off, you still need counter pressure for the frog. Overall, we had an 87% resolution rate. I would say the beads were really useful where traditional therapies had failed. So if you remember, over 50% of these cases were cases that, we did this gold standard and they still weren't responding. They were inexpensive in our hands, and I would say they're inexpensive because even if we use the Kerrier bead setup in the highest end antibiotics, you have a lot of beads that you can package and keep and use. And when you think about the cost of IV antibiotics in the horse, $500, $600 investment in making beads isn't that much for something that's going to last 2 weeks. And then the leftover beads are useful as well. The study supports that severe lacerations with synovial involvement have good resolution of infection if you combine this with traditional therapy, and that chronic draining tracts of the foot, you need to be aware that they can have a lot of problems with resolution of infection being lower and laminitis problems being higher. This is another example of what our farrier would do to help, where he actually put a Z-bar shoe on this. And you can see there's good frog support and you still have access to the affected area. I would say the infections have to be sensitive to the antibiotic impregnated bead for it to be effective. So I don't think just any antibiotic I don't feel like all beads are equal. So broad spectrum beads, when you don't have a culture and sensitivity, are probably a smarter use of what to put in. We do use them in combination with traditional therapy. I don't think you could just use the beads without something systemic that also is effective. And we had no serious complications with therapy. And I think part of that is because the beads were resorbed. I actually was a fan of Kerrier and met them at the meeting at VOS. And I asked them the difference between medical grade and what, I had started out with. And it's that their product is completely resorbed, or 99%. And I would say I definitely saw more reactions with the calcium sulfate that we just got over the counter versus what they provide us with. When we broke those down and put 20 beads in a package so they were ready to go, it still was inexpensive. If we charged $35 per package or 35 to 70 per treatment and needed repeat treatment, I still would consider that quite inexpensive. And they definitely have prolonged antibiotic release after you place them. And I have used them in cases with financial constraints. So I had a laceration that went into the elbow joint just recently, and they didn't know that it involved the elbow joint. There was some bone involvement by the time I saw it with the wound bed. And I was only allowed to do work on that horse standing, and I did have cultures on it, and we put beads in the area based on the cultures and debrided it standing, injected the joint one time and put the horse on the right systemic antibiotics. And the horse is coming around, the infection's resolved. I think the horse will have some arthritis because of the delay in treatment and the lack of being able to flush it, but it did resolve the infection, and that horse is probably going to make a pasture horse. This is one of the cases that had a severe tendon involvement, and they just want to use her for a broodmare. She's a long way out, but she had a complete transection of her superficial digital flexor tendon and about 50% of her deep flexor tendon. And that's her right now. I'd like to take any questions that you might have at this point.
Thank you, Dr. Stewart. That was an excellent presentation. Great data, great information. We really appreciate it. There were some questions that came through. I'm going to pull them up here. Question was, how do you charge for placement?
So usually I charge for the bead plus placement, usually like $70 for the bead. Then I charge for sedation. In addition to that, if I have to block, they get charged for the block. And if I use suture, they'll get charged for that. But a lot of the cases that I've been doing go directly in the wound, so there isn't a lot of suturing, but I'm usually doing a regional limb, a joint injection. So it's not, when you add it all together, it's not inexpensive, but it's, I think, a really important part of treating a severe wound. So I think you can make your own fee. I've gone back and looked, and I can say we make money on our kits and our antibiotics and our beads, and we have a better survival rate. So to me, it's a win-win.
Another question was, do you find that the beads affect the amount of scar tissue?
I think if you use over-the-counter product, you're going to have more tissue reaction. And if you use the Kerrier, I think it's really dependent on how heavy the infection is. So I think if you can get the wound really, really clean, maybe you don't need beads. You need to monitor it and see if it's appropriate. I think if you have pretty heavy contamination and you have bone infection, I think beads are appropriate because you're going to reduce the infection, which will reduce the amount of scar tissue that you have. So I think heavily infected and contaminated wounds, it's appropriate. I have seen where we have put them close to the or over the growth plate in the fold, that you can see that there's reaction associated with the bead. But again, I think the infection is the most important determining factor about, do we use this application or not?
Okay. We may have answered this question, but can you put different antibiotics in the same bead? I think you did kind of go over that a bit, but I think it's a good idea.
I would say, Myself, I routinely do because broad spectrum, you use broad spectrum IV antibiotics when you don't have a positive culture. And I would argue that the same thing pertains to the bead. And if it's not, I guess my concern, and you can address this, is if it's not susceptible, then it's more of an issue. Yeah, I mean, you don't want to put a bead in and have the bacteria to not be susceptible. So
Yeah. What is the shelf life of the beads once sterilized?
I think a lot of this, again, maybe you have more data than I do. If I gas sterilize them, I would use the same shelf life that you would on any other product that you would gas sterilize based on how you store it. So if you store it in a closed area in a clean, dry environment, it's going to have, I would say, at least a 3 to 6 month lifespan.
And that's what the literature pretty much says. We haven't done any testing specific to Kerrier, but there are multiple studies in the literature for ethylene oxide gas sterilization of plaster of Paris beads or calcium sulfate beads for multiple antibiotics. I actually have those references, so we're going to put up an email address at the end there. If you want to shoot me an email, I'll send you those references. Let's see.
We also discussed that early on, if you don't have ethylene oxide, we would put them in a sterile container. I don't know how long I would go with that, but I think if it's a matter of an hour or two, or, even, I think the gas sterilization is ideal, but if you don't have that, a sterile container for them to go in.
No, using sterile technique to mix and then place in a sterile container. I know that many surgeons are doing that. I mean, I hear it all the time. And there is some data coming out. There's one study that's going to be published for that technique. I don't yet know how they're going to prove the sterility, but we'll wait and see. I mean, it's packed with antibiotics, so it should be clean. The one question that did come up was fungus. Could fungus grow? But if it's a day, if it's a few hours or if it's overnight, like you said, I think it's probably safe.
I think in answer to that question, a couple of things so I use sterile gloves. I set up a sterile field, and if it's setting, I make sure I put it like inside a sterile surgery tray and put a cover over the tray while it's setting. That's what I do, is just like one of those sterile towels. In fungus, I would think penicillin might perpetuate a fungus, but it would have to be a moist environment. So if it's in a dry environment and being kept, in a clean, closed area in a dry environment, I don't think that you could get a fungal infection without moisture contributing to that.
There's another one here. In your standard of wound care, how often do you replace the beads?
I used to do it every 2 to 3 days. I would say I've definitely backed off from that. So that elbow that I could, like, literally, she took the horse, brought the horse to me to do whatever I could, and took the horse back home, showed up 2 more times, 2 weeks on the dot, 2 weeks for flaring up and the replacement of beads. The third time in the right systemic antibiotics, and the horse is doing fine now. But it was, I guess I would look at maybe 10 days if you think you need it. But I think I was probably overdoing it in the beginning.
Are there any contraindications to concurrent laser use?
I would say none that I can think of. I've had a number of cases that those carpal injuries that you've seen, I've had several of those that they've done laser therapy to improve the healing and then range of motion. And I don't see any overt contraindication.
What determines how many beads to place? Another question.
I feel a little humble about my lack of science in that area, as well as, the times I've used antifungals and that one time carbocaine. But I would say, typically I figure the minimum that I'm going to put in a decent sized wound is going to be 10 to 20 of those smaller beads. I don't know if you have any thoughts on that, but I think they have zones of inhibition. And so when you're doing them for tumors, you're looking at spacing them out for zones of inhibition. So I kind of try to follow somewhat along those lines for putting my beads throughout a deep wound.
And could they be used for conjunctive of an eye?
For what?
Conjunctive of an eye, conjunctiva of an eye, conjunctive eye?
I don't, I have had, I had a, but these were cisplatin that I bought, but I had a medial canthus where the third eyelid was taken off. And we actually, it was actually the lacrimal duct itself going down into the nasal passage was, affected. So you couldn't, even if you removed the eye, you couldn't have done, you couldn't have taken care of it. So we did do beads kind of spaced throughout the medial canthus of the eye. And that one so far is resolved. So I would think the conjunctiva, I don't know if you could put them in the conjunctiva because you might get irritation to the eye, but I think you can tuck them under the skin and be fine and get a zone of inhibition. So I think, you could probably answer that better based on what they do on the plate for zones of inhibition, antibiotic wise anyway.
Yeah, I mean, you're getting a couple of centimeters, 20, 30 millimeters are zones. So yeah, I've always heard that less is sometimes better, especially if you can get good closure, good tight closure. You don't want to overpack these wounds if you're closing them. So yes, less sometimes is better, and they do have a good zone. So you don't have to overpack. I think there's a couple more here. Are the beads feasible to use in an ambulatory setting?
So Dr. Colton does a lot of ambulatory work, and sometimes I'll take them with me, but we do, when I double package them, like you see, we will put them in a Tupperware container so they can't get wet, and we'll take them out with us that day. So if we're going to go do a case that we know has a known infection draining tract, we will take them with us that day and keep them in, because I think the biggest issue besides, weather exposure is you don't want to get them wet because and I think, getting things as clean as the wound as clean as possible before you put them in maximizes what they can do.
Okay, I think I got one last one here, kind of an interesting one. You mentioned using them for pain with morphine or fentanyl. Could you do the same with a local anesthetic?
So I think you could probably use, so the only place I've been careful is if it's anywhere close to a nerve. I haven't done it, but I think you could use, carbocaine in a local area and get a zone. And I certainly did in that foal. Like there was no question that foal was comfortable after surgery, started bearing weight immediately. And I mean, if he hadn't, he would have broken down on the other leg. I think morphine would be more appropriate if, all the classification and everything, but I think it would be more appropriate in that it doesn't have any, it won't cause any nerve paralysis. So I think if you put it high, close to the femoral nerve, that would be a real problem. So I think you have to be very careful with the carbocaine where you use it, but I think it definitely would be effective, just like how they're injecting around the TPLOs, right? That's basically an anesthetic, and it's no different if you're doing that with the beads.
Okay. I think that concludes the webinar. Again, we really appreciate your time and this information and data. Really good stuff. Please do not hesitate to email or call me anytime if you have any questions. Please visit Kerrier.com for more information or to place an order. It's very easy to do online. And we do appreciate you taking time to be on this webinar tonight. So thank you and have a good night.